Hi everyone. Hi everyone. Good evening. How are you all doing tonight? Okay. You guys have any plans for the weekend? No weekend plans? Study, hike? Probably talking to students. That will be my plan. Good. Nice to see you. Hey Amal. Uh, hi Mabel. All right. So did you guys come prepared a little bit with MSK with shoulder? Yes. Are you guys excited to get your questions correct? Okay. All right. All right. Okay. We have Sri here today. As you can see, she is one of our mentor. Also, she's moderating the chat. So if you guys have any question, if I'm not able to respond to your question, Shri will be there to answer your questions, okay? I'm happy to hear that, Mabel. Okay, all right. Now, are you guys able to read the chat, see the chat window? Everyone? Yes, okay, great. Okay, all right. So those of you attending it for the first time, if you were not present yesterday or last night's class, I'm Ankit and I'll be teaching you muscular and cardiopulmonary. And tonight we are going to study glenohumeral biomechanics, okay? Shifa Ben. Shifa, I'll ask them to fix things tonight. Usually, we recommend to enroll at least 1 or 2 days before the class starts because in the end, there's an influx of hundreds of students that can delay the process, but I'll ask them to speed it up as soon as possible, okay? And you can also reach out to Shri. She's one of our moderators. She'll be able to help you as soon as possible, okay? All right, so what are we going to finish tonight? It's a big class. We have close to 300 students. I'll try to answer all of your questions, but if I miss something, you can always reach out to me after the class, okay? So what are we doing tonight? We'll discuss about biomechanics, a lot of muscle actions. So make sure you're good with glenohumeral muscles. And if you have already enrolled in class, try to keep the PowerPoint, try to download the PowerPoint and keep it open in the next window so you can always go back and check the muscles. We'll discuss swinging, rhythm, impingement, tilting. Looks easy, but we'll have a lot of biomechanics. We'll have a lot of biomechanics, okay? So the slides are available to download from the website, from the student portal. So once you enroll, you'll have access to the website. Okay, all right, so let's start quickly without wasting any time. As you guys know, that's your scapula. Nothing to be taught about that. I'll quickly tell you one thing about them so that you can answer questions more easily. This is the superior border. This is the medial border. And this is the lateral border, okay? Very easy, very straightforward. So it has three borders, superior, medial, and lateral. And your spine is here in the center. That's your scapula, each side. Now, scapula has three angles also. Lateral angle, superior medial angle, and inferior angle of scapula. Why do we need to know all that? Even if we don't know the medial border or inferior angle of scapula, does that make any difference? Well, for exam purpose, it will make a difference because question will be mentioning patient has winging of the inferior angle of scapula. Not the whole scapula, inferior angle of scapula. So you need to know which muscle control inferior angle, which muscles control superior medial angle, okay? So three angles, three borders. All right. Let's understand quickly the movements. Okay, I'm going to show you the image, this one. If your scapula goes up, elevation, goes down, depression, it goes in towards the spine. That's called retraction. Okay, it's called retraction. Also, it's called adduction. Adduction of scapula. And when scapula goes out, protraction, also called abduction. Okay, important. Elevation, depression, protraction, retraction, and upward rotation. Upward rotation means, imagine this one. If this scapula, inferior angle goes out, up and out, like this, that's upward rotation. And when it comes down, downward rotation. Okay. All right. So we did that. Okay, let's do anterior and posterior tilting. If scapula tips like this anteriorly, forward, like here, goes like this, anterior tilting. It goes like this, posterior tilting. Okay. Is there something like medial and lateral rotation? Not needed, but for exam purpose, I'll just explain you. When you internally rotate your humerus, your scapula does this. When you internally rotate your humerus, your scapula does this. They call it intermedial rotation too. Okay. And when you externally rotate your humerus, scapula, the glenoid goes out and posteriorly, lateral rotation. Okay. All right. Just wanted to make sure that you understand all these movements before I give you a question. So we'll start with a question. You can always go back and review those things. Okay. Take a look at the muscle chart quickly. What muscle is this? Do you know? Rhomboid major. Awesome. Rhomboid major. This one, rhomboid minor, small one. Okay. Levator scapulae, superior medial angle. Okay. All right. And that's here. What muscle is this one? Serratus anterior. Awesome. Great. Great. On track. Let's do it now. Okay. All right. So now what you'll see on your screen, you'll see a poll on your screen. You'll see a question. You'll see one image. You can always enlarge the image by clicking on it. And you just have to answer in the poll A, B, C, D. Okay. A, B, C, D, just have to answer the poll, and that will be it. Okay. And please don't answer in the chat box so that others don't learn from you. Okay. All right, let's. Okay, guys, 5 more seconds. Okay, done. Okay, let's do one more. Same concept, the arrow is different. Keep an eye on the arrow, okay? From A to B, going more towards the center. All right, 5 more seconds. Doing amazing. Done. All right, great. Let's do those questions quickly, then we'll do the next set of questions. All right, the question is pretty straightforward, easy. When image questions come in the exam, what you should do first is always look at the image first. Look at the image first and figure out what are they trying to show in the image. So when your scapula moves from point A to point B, that movement is, as Himani mentioned, that's protraction. Okay, protraction. And which muscles are responsible for protraction? Let's say I don't know which muscles are responsible. So one strategy you have to apply in exam is, if you don't know the right answer, start eliminating the wrong ones. So do you know the function of infra and teres minor? What do they do? Infraspinatus, teres minor, what do they do? Okay, external rotation. Do they do anything on scapula? Not really, unless you block their insertion, but otherwise external rotation of humerus. Okay, latissimus dorsi, does it do anything on scapula? Depression, it can pull your scapula down, at least latissimus dorsi. Not teres major. Teres major is internal rotator, but at least latissimus dorsi can pull your scapula down. That will be depression, not protraction. That's gone. Option D says middle, trapezius, and rhomboids. What do they do? Retraction, bringing it back in. Okay. All right. C is right because it does protraction. Right, protraction is when your scapula goes out. So when you guys are practicing questions, if you just know C is right and you don't know ABC is wrong, you need to spend more time on that question, analyzing why is A wrong, why is B wrong, and why is D wrong. Okay, because a lot of time you'll get questions correct because you know C is correct, but if you're not sure A, B, D is wrong, that's a problem. Okay. All right, I think this was a fine start for everyone. Okay. All right, now what movement is this here? Downward rotation, more like a downward rotation, not retraction. Downward rotation may have some component of retraction, but this is precisely downward rotation. The inferior angle is going in. And which muscle is responsible for downward rotation? Rhomboids. Latissimus dorsi is a depressor of scapula. not a downward rotator of scapula. Different things, okay? Depressor versus downward rotation. So depression straight and downward rotation is like this, okay? All right, cool. And this is upward rotation. All right, so we'll do the next question, this one. From point A to point B, that's retraction. Which muscle is it? Levator scapulae also works with downward rotation too. You're right. So this is retraction, and what's the right answer? A, D. D is the right answer, correct. Middle trapezius, which is here, and rhomboids. Okay, cool. Any questions? All right. All right, so we have one more question. Again, it's a big class. It's hard for me to evaluate just by the answer of 10, 20 people. Maybe 90% doesn't understand or are not able to understand. 20, 30 people are responding in the chat box, which is good. But I want to make sure that 80, 90% who are not responding, ask your question. Feel free to ask your question in the chat box. If something does not make sense, you can always ask. And if you think we are going too fast, feel free to ask, okay? How can we just, there are combination movements, how to know primary muscles. So Prachi has a good question, combination movements. Now, are you talking about this question, Prachi? So Prachi, you're right, there could be many muscles doing the same job, right? So option D says, imagine option D says middle trapezius and rhomboid minor. And option C says middle trapezius and rhomboid major. Now, both are correct. So question is not asking which one, and they will not give you two correct options. That's not possible. So you have to eliminate. Okay, let's check the previous question. Is this the question you're asking for? Yeah, and what's the question? How do we know serratus anterior is the right answer here? We know because we are able to eliminate other options. Okay, but they can always replace, they can always remove. Tell me what can be other correct answer here. Is there any other correct answer? Upper trapezius. Now, is upper trapezius a protractor of scapula? Is pectoralis major a protractor of scapula? Tight pectoralis can cause some anterior tilting and medial rotation that may cause protraction. Yes, that may be possible. May cause protraction because of tightness, might be asked. But yeah, you have to eliminate. So there is a possibility you might see multiple correct and multiple options that look correct, but you have to eliminate. Supraspinatus for what? For protraction? Not really. We are not going to give supraspinatus to any protraction. All right, anyways, let's move on. All right, so those of you who are struggling with image questions, what you should do. Step one is figure out what movement is happening in the image. Okay, what movement is patient trying to do in the image? Okay, and secondly, let's say if I'm pulling something down or if I'm pushing something, okay, take a look at this. I'm trying to push a desk. What movement is that? If somebody asks you, tell me the muscles working at shoulder, what comes to your mind? Okay, all right, serratus anterior. Before you tell me the muscles, let's break it down. This is what movement is this? Flexion. All right, flexion movement. And what's happening at scapula? Do you know? Scapula is protraction. Good. Protraction of scapula. All right, serratus anterior. And if you mention about upper trapezius, that could be correct too here, because both of them upwardly, there's upward rotation of scapula also happening there. I'll teach you towards the end. How about pectorals? That would be right answer too. But let's say if somebody decides to mention rhomboids, will that be right answer? No. Awesome. So you should be in a position to say, no, this is wrong. If somebody, like, let's say option says latissimus dorsi, do you think that will be correct? Awesome. Latissimus dorsi will be wrong. If somebody tells you P major, correct. How about and deltoid will be correct. How about rotator cuff? They will work. They will work. Yes. Not even though there's no rotation happening, but they are still stabilizing. The moment you cross a certain degree, they start contracting. Okay. All right. So I'm going to show you the next question again. It's an image-based question. Take a look and respond there. Okay. You can always click on the image to make it bigger. Tricky one, so make sure you eliminate the wrong answers. And question is asking from 80-degree flexion to 0-degree flexion. Image might look like he's going in hyperextension, but just from 80 to 0-degree flexion. Okay. All right, 5 more seconds. You know what, like, remember those good old days when you know the answer and you just can't hold yourself? Let me just go right. Let me just tell the teacher. That's the right answer. Yes, I know it. So you guys are right. All right, let's do that question. Okay, not this one. It's a tricky one, so please don't break the chain if you know the answer. Let other students learn something, okay? Because it can be tricky for many students. All right, so first I told you to understand what movement is happening from A to B. What movement is this? Of arm. Extension. Great. It is extension from, let's say this is 80 degree and this is 0 degree. extension is happening. Now, when you're doing extension, what muscles work? Posterior deltoid and posterior deltoid. And what else? Latissimus dorsi and triceps. Good. Triceps, good. And so let's start finding those answers. Do we see posterior deltoid here? No, that's out of the picture. Do we see latissimus dorsi here? Do we see triceps here? Now, what extension are we studying here? What kind of movement is this? All right, so in this situation, you don't know. You knew these three things. You have no idea about these. All right, do you think serratus anterior can cause this at all by any chance? No, because in this movement, there is extension and downward rotation and retraction happening of scapula probably. None of that is done by serratus anterior. So at least I'm able to eliminate that, okay? How about lower trapezius? Can that muscle cause extension of humerus? No, why not? So Krishna has given an answer. Lower trapezius is an upward rotator of scapula. Okay, it's an upward rotator. The way it originates and inserts, it is an upward rotator of scapula, right? But somebody can question, when you're moving your arm down, there is some rotation happening. There is a rotation happening of scapula. What kind of rotation is that? Upward or downward? When you extend, it's a downward rotation of scapula. When you flex, it's an upward rotation of scapula, okay? So in this condition, there's downward rotation happening. Lower trapezius does upward rotation, that's gone. C or D, now we're dealing with, can rhomboid major cause extension? It may, right? It may, yeah, it may. So when you extend your arm, your scapula has to go downwardly and goes close to the spine. And you guys can practice it with me together. Like, bring your arm down, take it towards extension, and your scapula will go in retraction. Okay, that does happen. But if your scapula goes in retraction, that muscle will work, but that muscle will work concentrically, which means shortening of the muscle. Eccentrically means when the muscle elongates. So D is wrong. So that group of students who knew the answer, who could not just hold their emotion and type in the chat box about option C, I know C is the right answer. They were correct. Now let's ask from them, how do they know? Where did they learn teres major does extension? Can teres major do extension? Is that even possible? Is that even possible? Does it make sense? We should learn something, then let's do it. Now this is the proper biomechanics starting now. Are you guys able to see the muscle on screen? T major? Okay, good. Now this is important. Now the biomechanics start, okay? The origin of this muscle is inferior angle, more towards the lateral border of scapula, okay, from here. It comes down, comes up, and inserts on the medial lip. From down, inferior lateral border of scapula, and then comes up on the medial lip of lesser tubercle. Can that muscle do extension, or can that muscle help you with extension? How is that even possible? So now what happens is this muscle cannot do extension from neutral to regular extension, but this muscle, if you're flexed, and just imagine the muscle is attached here, this muscle can help to bring your arm up to the neutral position. This muscle does contract. If you do the movement against some resistance, this muscle can also contribute, maybe 10%, but we have to know that, right? So if we don't, that's always insertion of the muscle goes towards origin, right? So muscle inserts on the medial side of tubercle. Focus, 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 focus. Okay. Muscle originates from inferior angulosacula, inserts on the medial tubercle of humerus. Now, imagine this muscle is here, coming from down. Just think, this muscle can help me pull the humerus down, along with other extensors that you mentioned, triceps, latissimus dorsi, posterior deltoid. This muscle also contributes for extension. Okay. So it's always insertion going towards origin. Insertion of the muscle goes towards origin. You guys will learn a lot. You guys will learn a few more concepts. So I'm telling you, make sure you keep the PowerPoint open so you can understand, you can connect things better. And as Devanshi mentioned, this muscle will not work beyond 0 degree extension because this muscle then reaches the maximal shortening. Maximal shortening, it cannot shorten any further. But if your humerus is flexed, then it can help to bring your arm down up to neutral position. Okay. If a question comes, your arm goes from 0 degree to 40 degree extension, and the option is latissimus dorsi, teres major, which muscle is correct? Both of them are extensors. Answer is LD, not this one then. Got it? All right. I mean, if I know the answer, I won't be quiet too. I'll be writing in the chat box. So we don't blame those kids. If option D doesn't mention concentric, then D is more correct. Yes. If option D doesn't mention eccentric, that will be correct. If they mention latissimus dorsi, that will be correct. If they mention posterior deltoid, that will be correct. But they have not mentioned anything like that. So could the answer be middle trapezius if it was the option? No. Middle trapezius can work along with rhomboid unless it's mentioned as concentric contraction, then it can. Okay, then it can. Georgia, we started at 8 p.m. Okay, all right, guys. I hope you guys are connecting the dots. Okay, let me know if you guys have any questions. Okay, all right, let's move on. So other than posterior deltoid, you don't need to memorize any angle, not needed. Posterior deltoid will work throughout extension. Okay, from here to here. But teres major will only work if your arm is flexed to bring it to 0 degree neutral position. All right. Okay. Yes, Rodolfo, it's on the website and it's on the PowerPoints. All right, next thing is what you guys need to do, because you cannot excel musculoskeletal by knowing a muscle function. Hey, what does this T major does? Or what is the function of deltoid? I'll show you a question now in after a few minutes, or maybe 10-15 minutes, and you'll be surprised. Oh, is that the function of this? This muscle can do this? So what I'm trying to tell you is, if you know the function of P major, if you know the function of P minor, if you know the function of deltoid, but if you don't know how to connect, so that's like 0. goal is now how to connect, not knowing that memorization is that those time is over. Now we have got to focus on connecting the dots. Okay, so now after the class, what you should do, go home, figure out when you're brushing your teeth, what muscle is working. Eating, with you, whether you eat your spoon with a spoon, with your hand, that thing will help you improve your visualization ability or capabilities. Okay, when you're combing, think of some muscles. Right, so practice those things, because musculoskeletal is not something I can guarantee you're not going to learn in 15 lectures unless you grow your thinking, and I can guarantee you those 15 lectures will be more than what you have learned in your whole 4 years or 5 years of physical therapy. So grow your thinking, not memorize the answer. Okay, all right, so let's move on. Next question is again about how your scapula moves, or we can avoid that. I'll try to give it to you towards the end. Okay, all right, so that was about muscles. Next thing is ligaments. You guys can expect questions in your exams for ligaments, very important. And ligaments, there's a lot to memorize in that. Now, did you guys get a chance to watch the 3D anatomy lecture? Yes, okay. Did I talk about ligaments there in that lecture? So what is the function of superior glenohumeral ligament, anterior band? Avoid external rotation. That's good. What is the function of inferior glenohumeral ligament? External rotation. Yeah. So superior glenohumeral and inferior glenohumeral both prevent external rotation. All right. So how do we differentiate them? The range, in what range they limit external rotation, that is more important. Okay, so both of them are doing external rotation, but superior glenohumeral ligament will restrict external rotation at neutral or 0-degree abduction. 0-degree abduction, when you do external rotation, it is your superior GS ligament and anterior capsule. If your arm is up to 45 degrees or more, 45 degrees or more, inferior, 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 and it's anterior band when you do external rotation. When you do internal rotation, posterior band, inferior, 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 inferior. So it's pretty easy. It's not very challenging. You guys need to just revise it once or twice, and that you'll be good with it. Okay, so don't panic if you don't. And this is just memorization. If you don't know the concept, try to watch the 3D anatomy, so you'll have more clarity. Okay, so I'm gonna post a question. Give me 1 minute. Also, if you feel the class is going too fast, you can always put the message in the chat box. We'll try to see if we can slow it down. We'll surely try. Okay. All right. I guess 5 more seconds. Okay, done. Great. Also, you guys, when you guys get a chance, try to go through the slides. These slides have way too much information. It can be helpful for a beginner. It can be helpful for a beginner student to like go through it and understand it. Okay, can be very helpful. Functions of capsule, quite important. Okay. All right. So this question is, therapist is examining an athlete with upper extremity weakness and shoulder joint instability. Examination reveals increased anterior translation of humeral head during overhead movement. Now, when you see overhead, what does that mean? Overhead usually means your arm has crossed 90 degree, something like that. Okay, your arm has crossed 90 degree when you're doing abduction or flexion or scaption plane. So anything, it doesn't mean always abduction, but overhead elevation, they are all called overhead elevation, abduction, flexion, all of that. Okay, so when you do that, examination reveals increased anterior translation of the humeral head. Your humeral head is translating anteriorly, and there is increased translation. If you can see this is the humeral head, and that's the scapular glenoid. It's translating anteriorly too much. Now, who is supposed to stop them? Stop the humeral head from translating anteriorly? Who is supposed to stop them? Ligaments and capsules. And which ligaments? Which ligaments? Inferior glenohumeral ligament. Now, posterior capsule, if that is lax, posterior capsule, what will happen? If this capsule is lax, what will happen? Humeral head will slide posteriorly. So if you have not watched the 3D anatomy, try to watch it. Okay. So these things you'll be less lost with these basics. Humeral head going posteriorly, that means posterior muscles are all capsules and ligaments are weak. Humeral head going anteriorly, anterior ligament capsules, they're weak. Okay. D is wrong. Now, superior glenohumeral ligament, why is that wrong? Why is that wrong? Because question is saying during overhead movement, not at neutral abduction, okay, or neutral rotation. So now you have A or B. Now B also does not work beyond a certain degree. I'll show you the image. 0 to 45 degree. Okay, 45 to 60 degree, you have middle glenohumeral ligament. It does not work after 60 degree of abduction. The moment you cross 60, 60 is this much. That's not overhead. The moment you cross 60, it's all inferior, and anterior capsule. Okay. They prevent lateral rotation. And when you say lateral rotation, they prevent lateral rotation because at that time humeral head is coming anteriorly. So look at this. When you do lateral rotation, head is coming anteriorly. It's sliding anteriorly. So they work to prevent anterior translation. Okay. If you do internal rotation, your head slides posteriorly. So posterior capsule, these capsules will be correct. Okay. Got it? Okay, I hope you guys are doing good. Just make sure you go back and revise these important pointers. Very important for the exam. These basics are important. Okay. All right, so next topic for the day is winging of scapula. All right, winging of scapula. Shishir, you're talking about this one? Not there? I can check that. I'm not sure if we have updated it. Should be there. Might be written in a different way. It's just a different color. It is there, right? Okay, cool. It's there. Okay, so might be in a different color here. Okay. If not there, I'll give you. Okay, later on after the class. All right, let's move on. In blue, good. You got it. Awesome. Now, next topic of the day. Next topic is winging of scapula. So what we have done so far, muscles, ligaments. We'll have few more muscles because musculoskeletal is all about muscles. So we'll do more about muscles. Now, how are we doing? Are we going too fast, going too slow? How are we going so far? Good, slow, fast, okay. Okay, all right. Very engaging, awesome. Like that. Okay, so next thing is winging of scapula. Now, what does that mean? Wing. Wings, wings, wings. Let's understand it. What does winging of scapula means? So I already told you about the borders and angles. Okay. Sometimes what happens is these borders, superior, medial, and lateral borders, they go off the thoracic wall, thoracic ribs. All right, so ribs are like this posteriorly, and your scapula is sitting on that. Okay. But for some reason, either this border or this border or this border, or maybe just this angle or this angle protrudes backward. And how is that even possible? That's possible because if anybody's protruding backwards, that means the muscles that are supposed to hold it there are weak. So think of this one, this muscle, the levator scapulae, attaching here. If that muscle goes weak, or as Ritika mentioned, if I go in there and then stab you there and cut down your nerve damage. So now what will happen? That muscle will atrophy, weak. Now who's going to hold this border or this angle? Nobody. So it will protrude backwards, posteriorly. Okay. And if that happens, it's a muscle weakness. Okay. So if you notice any of the borders of scapula protruding backwards, any of the angles of scapula protruding backwards, it's because of weakness of muscle. Okay. If you see that the medial border goes in winging, that's called classical winging of scapula. If the medial border goes in winging, what muscles may be weak? And I would like to hear only from the new students. Serratus anterior, good. And that's not enough. Medial border. Now, upper trapezius does not insert on the medial border, so that won't be the right answer. Rhomboids, major and minor. And middle trapezius, okay. Rhomboids, major, minor, serratus anterior, middle trapezius. And you can also add the nerve there, okay. The nerve that is supplying them. Got it? Same thing if somebody tells you superior or inferior angle of scapula goes weak, then you have to decide. So I'm going to give you a question and you can decide accordingly. So basically, winging of scapula is any of the border or angles of scapula protrudes backward, maybe at rest or during movement. That's called winging of scapula. Okay. Cause is weakness of muscle or nerve injury, and treatment is, what do you think? If the muscle is weak, what should we do? Why not teres or major minor? Because they don't have anything to, they attach on the lateral border. They don't attach on the medial border. Then we do strengthening of that muscle, right? If muscles are weak, now how will you know the muscles are weak? How do you know? How do you check the muscle strength? Manual muscle testing. All right, so now you can understand, they can ask you a question or they can mention MMT of SA is grade 2 plus. What may be seen in the image? You will be noticing a classical winging of scapula. All right, so they may not have to mention precisely what you're expecting. They just mention MMT is poor, or what could be the MMT to have this kind of winging. Okay. All right, so I'll give you a question. All right, guys, 5 more seconds. Okay, done. Great. One more. All right, 5 more seconds. Okay. And one more. Okay. And you can always click on the image to enlarge it. I guess. All right, let's do it. Okay, all right, let's do the questions. This was the first question I gave you about winging. GH, instability and difficulty in lifting his arm and with a weighted object, something heavy. When he's lifting his arm, he's feeling instability at shoulder. Examination revealed medial border winging during arm elevation. So when you elevate, and they'll use those terminologies, so make sure you understand elevation means can be flexion, scaption plane abduction, or abduction. What could be the reason for medial border winging? Your brain should click something. Those same muscles, okay? And unable to complete full elevation. All right, so medial border winging is happening. Which muscle can cause medial border winging? Serratus anterior, but that's not the option. So give me something. What do you see in the option? All right, let's say you don't know the right answer. Tell me about option B. Why is that correct? Or why is that incorrect? Teres major should be incorrect. Why? So teres major is on the lateral border here, and minor is here. They attach at the humerus. They don't rotate your scapula up. They are not. Which border are they trying to control? Lateral border. If there is a winging of lateral border, yes, you can blame those muscles, but you can't blame those muscles if winging is on this border, right? If there's a problem here, you can't blame them just because they are on scapula, right? So they're wrong. How about upper trapezius? This border has gone in winging, this border. Can upper trapezius do anything there? No. They control this border, not this border. Okay, that's gone. Teres minor, no. Dang, so we know our answer. So always make sure, even if you know the answer, make sure you eliminate A is the right answer here. Medial border winging. Now, how is that muscle going to prevent you from doing full elevation? Can that muscle prevent? Not prevent, but to achieve full elevation, 180 degree. To achieve full elevation 180 degree, that means what you need to do? There's something called glenohumeral rhythm. 2 degrees from humerus, 1 degree from scapula. If that 1 degree is missing, you're not getting your full elevation. Okay. And if you have the muscles that are here weak, then scapula may not in every case, but may not move the way it should, causing unable to complete, so causing some problem in the end range. Okay. All right, so gradually you'll learn more on that. Next question was this one. All right, patient with a kyphotic posture complains of GH instability, difficulty elevating arm, winging of scapular medial border. Which of the following intervention? What will be most helpful for the medial border winging? Muscle training, right? Strengthen the muscles. So you'll strengthen the weak muscles. They can mention about right now here, option B is the correct one. You'll strengthen rhomboid, you'll strengthen serratus anterior, you'll strengthen middle trapezius. That will make sure that your scapular medial border stays on the thoracic wall. Now, why should we stretch this muscle? Yeah, Pankti, it can. kyphotic posture. It was slightly straightforward. So when you have this posture, the P major, P minor, P major, P minor, is there any other muscle that can be tight? Biceps. Okay. Any other muscle? Why not postural education? Well, the question is not asking the first step. Yes. Nobody mentioned about subscapularis. I think somebody mentioned, the name went missing. Damini mentioned about subscapularis. That muscle goes tight. All right, so we'll gradually have more on that. We'll practice it more and more. Because education cannot correct the problem, but that is needed to, right? Education cannot correct the problem, but that is important. Which of the following intervention will be most helpful in correcting the problem? If you educate somebody that you have to study, 4 hours a day, 5 hours a day, you have to go and finish the lecture, then you have to take quizzes, then you have to take practice exam. Does that mean that individual just will pass the exam? It can help if he follows, right? No guarantee, like if he doesn't follow. So here, that will be the step one, but not gonna fix the problem. Always, if the question is, we had the next question that was about performed first, then yes, first thing is this, then you don't try to fix this first you educate somebody. Okay, first you educate, and then second thing you try to fix. So this education will make sure that he understands what to do, what not to do. He's aware of that, but education doesn't fix the problem. But education is always the first step. But that question was asking, how will you fix the problem? That is done by muscles. All right, anyways. Now, these two questions were easy. Next question is, I'll request the old students who know the answers, let the new ones learn and don't take the opportunity from them to learn. So this is the question. The question is what you see in the image. Which muscle is overworking during resisted abduction? And please stay off the chat box, try to learn. Okay, try to learn what's happening here. Right. So in this case, what's happening is during resisted shoulder abduction. Okay, resisted shoulder abduction. There's a muscle that is overworking. Okay, there's some muscle that is overworking that is causing this kind of winging of scapula. I can assure you, you'll learn if you stay away from the chat box. Now let's understand, what are we trying to understand from this? What are we trying to understand? Okay, let me hide the chat box. It's more of a disturbance. It's hard to focus. Let me see. Give me 1 minute. Okay, cool. So let me explain it, and then I'll bring the chat box back. Okay. So what's happening is when you're doing resisted abduction, okay, which muscle works? It's your deltoid. Your deltoid is responsible to contract when you're doing abduction against resistance, or even without resistance, they are supposed to work. All right. Origin of deltoid is, as you can see in the image also, the deltoid has 3 bands: anterior, middle, medial, and posterior. Starts from the medial one, starts from the acromion and the spine of scapula. Starts from here and attaches here, like deltoid tuberosity. That muscle gives you that contour. Okay. Starts from here, goes to the deltoid tuberosity. This is origin, this is insertion of the muscle. All right. So when you do abduction, origin of that muscle is trying to go towards insertion. Sorry, insertion is trying to go towards origin. Okay. When you do abduction, insertion is trying to go towards origin. Now, imagine some heavy individual is trying to block your arm from going in abduction by some heavy resistance. Like block that movement. Imagine you're trying to abduct and I'm like sitting on, hanging on your arm and not letting you take your arm up. That means not letting your insertion of deltoid to go towards origin. In that case, what may happen is there's a possibility, if the stabilizers are weak, there is a possibility that the origin will be pulled towards insertion because that muscle is trying to shorten. The origin will be pulled towards insertion. Now, if the origin gets pulled towards insertion, what may happen? Your arm will not come up because insertion is not going anywhere, but your scapular border, I'm going to clear the screen again, part will go towards insertion, causing, what kind of rotation is this? This is downward rotation of scapula where your inferior angle goes in, superior angle goes, or this angle goes out, downward rotation, all caused by deltoid. All caused by deltoid. Okay, so if there's a possibility that if you don't let the insertion of the muscle go towards the origin, if you don't let the insertion of the muscle go towards origin, muscle is trying to shorten. The origin will be pulled towards insertion. If the origin gets pulled towards insertion, it will cause this part to go down, causing downward rotation of scapula. Now, who is supposed to prevent downward rotation of scapula? Now, in this image, who's supposed to prevent downward rotation of scapula? This is downward rotation actually. Your scapula is like this. Who is supposed to prevent downward rotation of scapula? Serratus anterior. Awesome. Awesome. Okay. That means that muscle is weak. So your deltoid will only be able to pull origin towards insertion if scapular stabilizers are weak. Okay, if scapular stabilizers are weak, deltoid will be able to pull origin towards insertion. And here it's going downward rotation. So here your serratus anterior has to be weak to let your deltoid cause this kind of posture to this female patient. Okay, so tight muscle or overworking muscle is deltoid, and weak muscle is, here is serratus anterior. Okay, now why is option A wrong? Why is levator scapulae wrong? Think. What can they do? Does that muscle do abduction of arm? Why is that wrong? So that muscle has nothing to do with arm abduction. You got to think. You may not find all the answer, but you got to think. Muscle originates here, inserts here. Okay. Why is that wrong? If that muscle originates here, inserts here, why is the whole border is like protruding backwards? And that muscle can only pull this angle up. They cannot rotate the scapula like that. That muscle has to be tight to cause a little bit of downward rotation. A little bit of downward rotation. Along with, there should be elevation. Okay, so that muscle is actually wrong. Rhomboids. Why is that wrong? Why is that wrong? Yeah, it's weak. Okay, now tell me, let's say this question is asking, what do you see from the image? Here it's downward rotation of scapula and winging of scapula, right? Downward rotation and winging of medial border. Now, if rhomboids are weak, pay attention, rhomboids are weak, you'll have winging of medial border. But if your rhomboids are weak, can you also have downward rotation of scapula? No, because that's their function. They have to contract strongly to cause downward rotation. They can't be weak and still have downward rotation. Okay, all right. A is gone, B is gone. Middle trapezius. Why is that wrong? Even though you know deltoid is right, the ones who know deltoid is right, you better explain why is it wrong? Is this wrong? So middle trapezius can cause retraction. It doesn't cause any downward rotation. It causes more of a retraction. Okay. Here the scapula is rotating downward. Okay. Even if the motion is not resisted, let's say Bhumika is asking, do you think that will make any difference? What do you guys think? Will that make any difference? Let's say there is paralysis of serratus anterior. So technically it doesn't matter. If there is a paralysis of the muscles stabilizing your scapula, if they are paralyzed, you'll see the same results. Okay. So in this case, deltoid is the right answer. Now this is biomechanics we are talking about. Again, who studies deltoid does downward rotation of scapula? No, nobody. But when we are practicing question exams, this is what we want to achieve to be able to get answers correct. Okay. So if your deltoid will overwork, it can pull the origin towards insertion, causing downward rotation of scapula, and medial border winging will be visible because of serratus anterior weakness. Now, you may memorize this concept, but they'll confuse you. Can you apply this concept of origin towards insertion, origin of muscle going towards insertion, anywhere in the body? Can you apply it? And give me some example. Give me some example. And old students, guys, I know your names, so please stay out. Yeah, gluteus medius can be one. So origin, insertion. Tell me, what do I have to do to pull the origin towards insertion here? What should I do? Abduction, resisted abduction. It should be blocked. It should be, should it be isometric, or should it have some movement? Isometric will give actually results if it is regular movements. If there is movement happening, that means insertion is going towards origin. Okay. If there is movement happening, you'll only see origin being pulled towards insertion if you're not letting the insertion of the muscle go towards origin. Okay. So if you do resisted isometric abduction of hip, of femur, there's a chance it might pull the might try to pull the pelvis down. Okay. Any other example? Any other examples? Now old students can jump in if you know the examples. Biceps is one. Okay. Anything else? Knee hyperextension. So I think Krishna mentioned about knee hyperextension. Krishna, which muscle are you talking about? Plantar flexors. But which plantar flexors, Krishna? There are too many plantar flexors. Which plantar flexor are you talking about? Are you talking about soleus? Gastroc. So what we need to understand is gastrocnemius is a two joint muscle. Pay attention, guys. Pay attention. Is a two joint muscle. It inserts originate at your, where does it originate? Origin. Femoral, distal femoral condyles, posterior condyles at your knee area. It originates. And where does it insert? Achilles tendon or calcaneus. Okay. Now think, origin is the posterior part of condyle, femoral condyles, insertion at Achilles. Function of this muscle is plantar flexion. Imagine that's my foot, that's a muscle, and if I don't let you plantar flex, what may happen? That means I'm not letting the insertion of that muscle go towards origin by not letting you do plantar flexion. So what will happen? Origin will be pulled posteriorly. Origin will be pulled posteriorly, which is condyles. Femoral condyles will be pulled posteriorly, causing hyperextension. Okay. If femoral condyles come posteriorly, that is hyperextension of knee. Femoral condyles pulled posteriorly, that is hyperextension of knee. Can it be soleus? Can soleus do something like that? No. Soleus cannot. It's just a one joint muscle. Can plantaris? No. One joint muscle. Now, how is it going? Are you guys able to open up that thought process, the connections? Yeah. Okay. All right. All right. So that was one example. Just go through the PowerPoint. Serratus anterior. Tell me about serratus anterior. What can that muscle do? The origin, like that's the spine, pelvis, scapula, humerus. That muscle originates from here, here, and it also goes and inserts at the shoulder. What it can do is, function of that muscle is, what is the function of latissimus dorsi? Extension, medial rotation, right? So if I don't let the insertion of that muscle go towards origin, what do you think may happen? Hip hiking. It will pull the pelvis. It may pull the pelvis up. It may pull your spine laterally. Right? It has some origin on the spine also, right? As far as I know, it does have some. I might have to check again. It has, right? It might cause anything. That's what you need to develop. Anterior tilt too, awesome. So that muscle actually originates. So it actually originates iliac crest, but more like posterior superior iliac crest. So it can pull the pelvis up, but when it pulls the pelvis up, it will have anterior tilting. Okay, so that's what we need. True, Prachi, pelvis is strong. Is scapula not strong? Now, all this thing happens if the muscle that is stabilizing, like in the scapula question, I said that your scapula will only go in downward rotation, or deltoid can only pull the pelvis or scapula in downward rotation if who's weak? Who's weak? Serratus anterior. Here, if some other muscles are weak, latissimus dorsi can do that. Okay. Again, keep in mind you may not see a huge movement because the joints are blocked, but you'll see tilting. You'll see tilting and all those things will be visible. Okay, got it. All right, so I hope you guys were able to connect all that. Make sure you go and practice it to build up your understanding that muscles have different connections. Now, step one is knowing the function of muscle. Like let's say latissimus dorsi. You know it does extension, internal rotation. You're not going to ask this. Also, you need to know muscle origin insertion. You don't have to be accurate with origin and insertion, but you should have an idea. If somebody says patient's inferior angle of scapula is broken, what do you think? What muscle may be damaged? Something that attaches on the inferior angle, that is latissimus dorsi, right? And once you know all this, what they will ask is your ability to connect that. So they're not going to ask you the function of the muscles. Those days are over. They'll be asking you the connections. Like they're not going to ask you the function of deltoid. Even if you're not a physiotherapist, you'll know the function of deltoid. They'll be asking you how deltoid can cause scapular downward rotation. Okay, so that, but to reach that level, you need to complete the initial level 2. All right, this is basic that you need to know. Then you'll be able to think of biomechanics. Okay, all right, so we'll move on. I hope you guys are not completely lost and confused. Just go home and study, will be good. I guess 5 more seconds. Okay, done. We'll do one more. Let's see, let's apply your concepts. Are questions bothering you, or they are okay? I guess 5 more seconds. Okay, done. Options are confusing. True. Only then you'll learn. If you see a question in your, oh, C is the right answer. You're not going to learn anything. You're wasting your time then. So you'll only learn if there's something new. Now imagine you pay us $500 and we teach you something you already know. Will you be delighted? Would you like to see something like that? Hope not. So every day you guys will be challenged. Probably might make you feel that you have no idea, but that is how you grow. That is how you grow. Okay. But good that you are able to understand your limitations, and it's all about your willingness to work hard in that direction. All right, this question, which of the following is an appropriate manual muscle testing technique of upper trapezius? How do you test upper trapezius, or how do you do manual muscle testing of upper trapezius muscle? Somehow I'm not able to see the chat. Shoulder shrugs. So this is shoulder shrugs. This is shoulder shrugs. Shoulder shrugs. B, sitting shoulder shrugs. All right. So all shoulder shrugs. So the question is asking gravity eliminated plane, which is grade 2. Grade 2 is gravity eliminated plane. So which one is gravity eliminated plane? A. Option B is what grade of muscle is being tested by option B? Grade 3. Option C is also grade 3. Right? So A is the right answer here. Anyways, that was good. Not doing this one. Okay, so the next question was about glenohumeral rhythm. Okay, so let's do that quickly. As you guys know, GH rhythm is important. Okay, glenohumeral rhythm is quite important for exam. They're not going to ask you tell us how much scapula moves or how much humerus moves or how much clavicle moves. They're not going to ask that. But probably you won't be able to answer a question if you don't know it. Okay, so when you do arm abduction, you might have read 2:1 ratio, 2 degrees from humerus, 1 degree from scapula. So 120 degree of abduction comes from your humeral movement and 60 degree comes from your scapular movement. So here, if your scapula does not move, you will not be able to do full abduction. Okay. On top of that, your humerus goes in external rotation. And look at that, 90 degrees of external rotation. And how much is 90? This much external rotation happens of humerus. So humeral head turns completely. Take a look at this. That's your greater tubercle, glenoid. So greater tubercle is in the front, goes up. You can't even see the greater tubercle anymore. Comes back down like that. Okay, that much external rotation happens. If that does not happen, that's a problem. We'll discuss that. So just remember, for exam purpose, 120 degree from humerus, 60 from scapula. Your humerus rotates externally 90 degrees. And apart from that, clavicle, 30 to 40 degrees of elevation and 30 to 40 degrees of external rotation. It also rotates posteriorly. So make sure you guys are just aware of that part. Okay. Now going to the question about rhythm. This question is asking poor GH rhythm. That means what? Humerus and scapula are not moving in sync. Examination reveals patient hikes his shoulder. So when you're going beyond 90, you might have seen people doing this. Due to reduced scapular mobility. So when it's time for you to go above 90 degree, you're doing hiking because your scapula is not moving. Now, how should your scapula move? Should it go in upward rotation, right? So when you go in abduction, your scapula should also go in upward rotation. If that doesn't go upward rotation, what could be the reason? Which muscles might be tight? The muscles that hold the scapula from the medial side. The downward rotators would be tight. Which are downward rotators here? Not this, not this, not this. D. D is a downward rotator. How can that muscle? Do you know origin insertion of that muscle? That muscle originates over here, your cervical spine, here, and inserts at this area, and more on the superior medial side of the angle. And so imagine that muscle comes over here. It's coming from the top, like this. Now look what will happen. Normally it's like this. If I pull that muscle up, what happens? Look at this. That muscle will cause elevation with downward rotation. Elevation, it will cause downward rotation. Okay. That muscle needs to be stretched to let you take your scapula in upward rotation. Okay. So D is the right answer. All right. We have a few more questions on that. Now, this is again important concept, and I want you to remember this. Focus, 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 otherwise you'll be lost. When you do arm abduction, 0 to 90 degree, what muscles work? 0 to 90, what muscles work? 0 to 90, what muscles work? Supraspinatus, and I'll say it, let me write down from 0 to 15 first. 0 to 15 degrees. Which muscle? Supraspinatus. Okay, supraspinatus. 15 to 90. Which muscle works? Deltoid. That means, does deltoid stop working after 90 degree? Who's taking my arm to 180 degree? 90 to 150. Which ones? Serratus anterior and upward trapezius. That's gone to now 150 to 180. Before that, so imagine if these muscles are paralyzed, upper trapezius and serratus anterior, you'll not be able to lift your arm above 90 degree abduction. Okay. The scapular muscle, they don't even originate or insert on your humerus. So how can they help me achieve full elevation? So what happens at first is your scapula is moving, and then it goes like this. Your upward rotation of scapula helps you get 180. Okay. So 90 to 150 is from these two muscles. Now who's helping me? Now what I want you to do, all of you guys pay attention. If you're sitting in a chair, sit flexed, and try to achieve 180 degree. Let me know if you're able to do that. No. Anybody? Now sit straight. We got some unique ones. Sit straight, and we got some students proving the books wrong, but sit straight and let me know if you're able to do that. So now what's the difference? The ones who got it in this position. Yeah, that's not what you got. That's not 180. You might think, oh, I think I made it. That's not 180. That's not how 180 looks like. And sit straight and then do. That's how 180 looks like. So the difference, what's the difference? It's the trunk. It's your spine. Thoracic spine. Thoracic spine. It has nothing to do with cervical. Your thoracic spine goes straight. You can do that. Okay. Now try doing bilaterally with this flex posture. You won't be able to. And this is not 180. Sit straight and sit a little bit more extension. Try to do more extension at lumbar spine. You'll see it going more smoothly. So I want you to feel it. Feel it. Okay. First, you're starting like this. No, it's not happening. Okay. Then extend thoracic spine. Yes, I can do that. It's getting tight. Extend more. Yes, I can do more. That means if you're doing one arm 180 degree, you want your thoracic spine to go in extension. If you want bilateral arm to go in full abduction, you want thoracic and lumbar spine. Thoracic and lumbar spine to go in extension. Otherwise, it does not matter how good your muscles are, you will never be able to achieve 150 to 180 degree. Now tell me the patient who will never be able to achieve 150 to 180 degree. Who may have problem in achieving that? And who has kyphotic posture? Tell me some pathological condition, like some conditions. Ankylosing spondylitis, flex posture. Anybody else? Parkinson's. Those people. So don't try to fix their full abduction. It's not the shoulder joint restriction. It's the spine that is causing that, okay? So make sure you guys connect all these things when you're treating a patient, okay? Good. All right, I'll give you the next question. Can you handle a little more, half an hour more? Are we able to catch up with the content? Yes. Okay, good. Let me see. It's 5 more seconds. Okay, done. All right, let's do the questions. So the question is asking, therapist is treating patient with reduced GH mobility. there's no joint pain, reduced mobility without any joint pain, and the patient is not able to achieve full abduction. Now, before you go for the options, your brain must think, what do I need for full abduction? I need what? I need GH rhythm. I need my scapula to move properly. I want the 2:1 rhythm. I want my humerus to rotate externally. I want my muscles to work. All of that, right? So which of the following will be inappropriate intervention here? All right, so if I don't know inappropriate, let's find the appropriate ones. Do I need strengthening of these muscles? Can these muscles help? They can help. Awesome. Awesome. How can they help? By helping you do external rotation. Who's doing 90 degrees of external rotation? Them. Okay. Especially with overhead movements. All right, do I need this? Cervical extension will automatically happen. There, yes. Do I need this? Yes. Do I need anterior glide? Now, what's the difference between anterior glide? So, when you do abduction, there is an external rotation. There is an external rotation happening of the humeral head. So you might feel that humeral head is going anteriorly, but it's not just going anteriorly. It's not going like this. It's rotating. Okay, so you won't be giving anterior slide to achieve that. That will be inappropriate. Anterior glide is not something recommended there. Yeah. Or am I missing something? Give me 1 minute. Which of the following is an inappropriate intervention? Give me 1 minute. So that should be anterior slide, because if somebody has restriction with external rotation, hold on, let's clear it. So if I have anterior capsule tight, hold on. If I have anterior capsule tight, it will restrict. It will not let your humeral head rotate externally. Like in the beginning, what we studied, if your anterior capsules which are present here, if they are tight, they won't let your humeral head rotate externally. So that slide can help you achieve that flexibility. So that's not the inappropriate one. That should be okay. This is okay. This is okay. Strengthen rotator cuff muscles. Which of the following is an inappropriate intervention here? With reduced shoulder mobility without any pain. Okay. All right. If you'll only strengthen these muscles if patient has pain, because these muscles will help to pull the humeral head down. And if they are weak, you'll have impingement. So the patient complains of pain, yes, that's what we need to work on. But if there's no pain, then we don't need to work on rotator cuff, because they're already strong. They're holding the humeral head down. We have the concept of impingement, so just hold on for that. I think after that concept, you'll be able to connect it more. But here, because of that pain thing is mentioned, that there's no pain, we don't need to strengthen this muscle. So D is actually the right answer here. Okay. All right. Why not A? Because your humeral head must have mobility. When you do external rotation, what happens? And imagine your anterior capsule is tight. It won't let you do external rotation. It won't let you do external rotation if your anterior capsule is tight, and that will be an appropriate intervention in that case. Yeah, so hold on. If it is mentioned about pain, we have the next condition called impingement. You will be able to connect more, right? You'll be able to connect more after that. Okay. Inappropriate is option D, not A. Okay. Here. That's what we need to. That thinking we need to connect. Okay. Let me finish. Okay. How is A correct? Because when you have external rotation of humerus, what happens? If patient is not able to achieve full abduction, you do want external rotation. When the external rotation is not happening, how do you achieve external rotation? If a patient is not able to do external rotation, how do you gain external rotation? What do you do? They're talking about abduction. That's what we did. Abduction has 90-degree external rotation. You will not be able to abduct if your arm does not go in external rotation. Abduction has 90-degree external rotation. That was the trick point earlier. Look at this. 90 degrees. If it doesn't go in external rotation, you'll never be able to achieve full abduction. Yes, that's right, Alman. Okay. So this, you do need that, right? Let's say patient's rotator cuff is weak. That's pretty straightforward. I mean, you learn from it. Painful for what? Capsules are not designed to cause pain. They are tight. You'll feel tension, no pain. You'll always feel tension. Okay. Right. Now, let's say somebody's rotator cuff is not strong. What will happen? Impingement. Awesome, Rabab. If your rotator cuff is weak, you'll have impingement. How do I know if I'll have impingement? I'll have pain. Shoulder pain. Okay. So hold on, guys. Let me explain. Let me teach you something. I can see that based on your answers, inferior glide, this and that. Let's understand the next concept. That will blow your brain completely and might help you think better that way. So let's finish this. And you can always watch the recording. If something is not clear, you can always watch the recording. But we can finish this first and we can discuss your questions. Next important condition is impingement. Subacromial bursitis, glenohumeral impingement. Take a look at this. Subacromial bursitis. Pay attention, pay attention. Subacromial bursitis. This is your acromion. Okay, acromion. And this is that acromion. Okay, acromion. What is this thing called? Acromion. What is this thing? Coracoid. And what is this thing? Humeral head. Now let's understand the connection. Like, look at the space. How tiny the space is. Acromion, humeral head. That space is like so small. Look at this. You have a subacromial bursa there. Supraspinatus tendon there. There's another bursa present there. Too many things in that small space. It is very, very small. So pay attention, otherwise you'll be lost. Very small space. Now, sometimes your bursa gets compressed. Sometimes your humeral head can go up because of some weakness or something else when you're doing abduction, and it can compress all of that. So imagine you're doing abduction and humeral head slides up too much, compressing the bursa. That's called, that will cause subacromial bursitis. Because if your humeral head slides up every time you go for abduction, that will start irritating the bursa, subacromial bursitis. Eventually, it may also cause supraspinatus tendinitis, because every time you abduct, those structures will be irritated by acromion. All right. So what is the cause of subacromial bursitis? Compression of these, either bursa or tendon between these two structures, acromion and humeral head. Okay. So now just think, this is acromion, this is the humeral head. If this slides up, it will impinge those structures, causing bursitis. Okay. Now, how do I treat this problem? It's also called impingement. Okay. You know the mechanics, like this slide up, either your humerus goes up, scapula comes down, compress the bursa, impingement. I would like to hear from the new students only, please. So cause or split. Now, how do I fix the problem? How do I make sure I don't have that, or I don't experience that? Okay, new students, scapular elevation, new students, please. First, find the cause. Okay. What could be the cause? Not letting the humeral head slide up. Why is it sliding up? Maybe fix the posture. Okay, let's say posture is not a problem, it's fine. It can happen in young individuals also. So let's understand, focus. What do I need to do? My goal is, all right, stay away from the chat box, focus, understand this. My goal is to increase the space. Increase the space between acromion and humeral head. How do I increase the space? Either you can pull the humerus head down, or you can let the acromion go up. Either pull the humeral head down, take the acromion up, that will increase the space. So teach me something that will help me pull or bring the humerus down. Traction, gliding, inferior gliding of scapula. So just bring it down. Bring it down, right? Now, if you do it one time, will it stay there? No, I'm going back to acromion. So why do we even waste time? Why do we even waste time? What should we do? One thing that will make sure if it comes down, it stays down. What should I do? Brace. Brace is like blocking. Strengthen medial rotators. Okay, let's say you strengthen medial rotators. Which ones are medial rotators? Pectoralis major, right? Subscapularis, pectoralis major. Imagine you strengthen pectoralis major. It won't let you external rotate your arm. We need external rotation also. Okay, we need external rotation. Okay, so I'm going to tell you the answer. Traction, pushing, all of that is contraindicated. That's like contraindicated. Let's understand one thing. So pay attention, guys, and you can focus on the class so you don't get lost with the chat box. Look at this muscle. I'm going to share this. Imagine that's your scapula and acromion and humeral head. Okay, now let's think infraspinatus is below the spinous process here. I'm going to give it a different color. This muscle. Infraspinatus muscle originates from infraspinous fossa and inserts on the greater tubercle, right? Below in supraspinatus. Origin, insertion. Pay attention, okay? It's concept. What is the function of this muscle? Infraspinatus. External rotation. You know what? Now, is it possible if I do this thing? Can that pull my humeral head down? Doesn't make sense. Only new ones, please. Can that pull my humeral head down? doesn't. No, good. It may not, but let me help you a little more. Now what happens is that muscle actually, now you have to focus on the origin insertion of the muscle. Goes from here to up, origin, insertion. It will externally rotate. But look at the arrow. It will also pull the muscle, the bone down. Not like this, but slight depression can fix the problem. So external rotators can help you pull the humeral head down. So if you just do this strength training, that muscle will get stronger, but at the same time, because of the line of pull, it is pulling the insertion towards origin slightly downward. It's not just straight external rotation, it's like downward external rotation. That pulls, and that will strengthen. If the muscle is strong, the humeral head is not going back up, it will stay down. Okay, so infraspinatus. Tell me any other muscle that can do that. So I want two things. I want to make sure that I have external rotation, and I want to make sure my humeral head goes down. Tell me two things. Teres minor, awesome. So infraspinatus, teres minor. How about teres major? Should I do that? Teres major? No, absolutely not. Why not? Where did I go lost? Teres major is an internal rotator. Now, why do I have problem with internal rotation? And why do I want external rotation? Apart from GH rhythm, does it have any significance? External rotation. Does it have any significance? It does. Look at this. If you have subacromial bursitis, you'll have pain in the range of 60 to 120 degree. It's called painful arc. You don't have pain before that, you don't have pain after that. What kind of problem is that? That doesn't hurt me after or before. What happens after 120 degrees? Or why do I have pain only in this range? So pay attention, focus. It's all conceptual, so you have to understand why previous question we were doing something that we were doing. All right. Understand this. If I'm doing abduction and look at my greater tubercle, that's where supraspinatus, infraspinatus, teres minor insert, acromion. If I go up straight without external rotation, see what happens. Going up straight, I'm hitting. And now look what if I do external rotation. So if I go up straight, the tubercle will hit acromion. There won't be any space left because tubercle is like protruded structure. And that is why God was pretty much like a biomechanist. He knew if I don't rotate his shoulder, he'll have impingement. So let me rotate his humerus so those structures can clear acromion without getting impinged. So those people who have less of who have poor external rotation, they'll have impingement. Okay, they'll have impingement. So we want external rotation. Now, why do I have no pain after 120 degrees? Because after that, those structures cross acromion. So they are actually under acromion in that range, 60 to 120 degree. They cross acromion after that. That's why you don't experience any pain after 120 degrees or below 60 degrees. That last 10 degrees pain is coming from a different structure, not from subacromial bursitis. Okay, so now when I treat subacromial bursitis, what do I need to do? I need to do two things. pull the humerus down and externally rotate. Okay, which will pull the humerus down and external rotation? Which muscle? Which muscle? Which muscle? Come on, quickly. Infraspinatus and teres minor. Would you like to strengthen subscapularis? You should not. You should not, because what are you going to achieve with that? That muscle will promote internal rotation. And do you really need internal rotation in impingement? Technically not. Okay, we don't need that. You can't stretch. Why not? So Elman, if usually people who have this kind of posture, they have actually those muscles already tight, and they are the ones who have weak external rotators, and they are the ones who are prone to develop that impingement. So technically they already have tight internal rotators. Yeah, you can stretch it. Sorry, I misread your statement. You can stretch it. Does it make sense, everyone? So I need to do a few things. External rotation. How do I depress my humerus? Strengthen your infraspinatus teres minor. Now tell me one thing. How many of you have treated bursitis and ended up strengthening deltoid? Like deltoid. Because I personally felt that deltoid is the best muscle that will fix all my problems. Now, should we strengthen deltoid? Should we? We should not. Why not? What's going to go wrong? It will pull your humerus head up. Okay, so that muscle originates here, inserts here, deltoid tuberosity. The muscle is coming from top to bottom. How do I remember all this? The muscle is coming from top to bottom to your deltoid, so from top to down. Imagine if that muscle will contract, what kind of action you'll see there. Like what will happen to humerus? Will it go up? Will it go just in abduction? And that muscle is coming from scapula here. Insertion, origin. That muscle does abduction, right? But the muscle will pull the bone up. Even slight up, impingement. So it's contraindicated to strengthen deltoid. Okay. So this movement is not going to fix the problem. This movement, gradually in different ranges, will fix the problem. Okay. And it can cause downward rotation of scapula too, more impingement. So we did of humerus, what to do. How about how about scapula? Who can take the scapula up? Which one? Upper trapezius. Upper trapezius can take scapula up. That one is more important. And that's how we treat. Now, some students mention about levator scapulae. Would you like to strengthen levator scapulae? Would you like to strengthen levator scapulae? That is an elevator of scapula, right? It should take the scapula up. Why not? Okay, so look how it takes scapula up. Pay attention. Scapula has gone up, but it's causing downward rotation. Now, do you want acromion? Look at acromion. Do you want that to come down? We are making the problem worse. We don't want acromion to come down. We want acromion to stay up, not down. So we have to selectively pick which elevator. And that's where the life gets interesting as a physical therapist. That's what makes you smart. When you can differentiate a muscle that is levator scapulae versus another muscle that is upper trapezius, both are elevator. But you can strengthen this, and this is the wrong answer. That's contraindicated, and that's the right answer. That's what you need to improve or learn. Why upper trapezius? It will take this end of scapula up and elevation. Levator scapula will take this end of scapula up and elevation. Got it? Make sense? All right, now I'll go back to the previous question and I'll try to help you answer that question. Okay, you can always go back and review this one. So if I have problem with this muscle, I'll have pain. That will be impingement. So basically this meant over here, there's no pain, no impingement. That means this muscle is already good. So that will be inappropriate intervention here, okay? All right, so how are we doing so far tonight? Is it too much? Your brain is roasted, confused, feel like giving up? It's completely okay. Everyone feels like that. The ones who are successful are the ones who keep going. That's the only way out. Okay. That's awesome, Amal. Good to hear that. We'll just end one topic of the day and then we'll again meet you guys tomorrow if you guys are attending tomorrow. Just remember, if your scapula tilts anteriorly, anterior tipping, tilts posteriorly, posterior tipping, which muscles can cause anterior tipping? Which muscles can cause anterior tipping? P minor. All right, let me have, I'm going to show you a question. Take a look at this question and try to answer it. So Rabab, if a rotator cuff is good, it can do external rotation, but that rotator cuff cannot guarantee for capsule. If capsule is a problem, you don't strengthen rotator cuff. Even if you strengthen rotator cuff, will that fix the capsule? Two different things. This one, anterior tipping of scapula is mentioned, which will be primarily and directly responsible for anterior tipping. You have two options, P minor and major. Tell me why not major? Insertion. So P, what is the attachment of, what is the origin of P minor? Third, fourth, fifth coastal cartilages, not coastal cartilage, third, fourth, fifth ribs, and inserts on the coracoid process here. Your scapula is like this posteriorly. They insert on the coracoid process. Okay, and tell me if that muscle gets tight, your scapula will go anteriorly, but it will be pulled in because it will be pulling the coracoid inwards, anteriorly and medially. Right now, why not P major? P major originates here, second to sixth coastal cartilages, attaches on the humerus. It has no origin, no insertion on the scapula. If that muscle gets tight, it will focus. It will affect your shoulder and posture, but that muscle is not primarily and directly responsible for anterior tipping. Make sense? Others are not connected at all. All right, so come prepared tomorrow. We'll have more. Make sure you go through the slides, practice, build up your understanding. The class is done tonight. You'll see the lecture. Lecture will be posted on the website. Where do I find on the website? Where should I find it on the website? On website, what part of website should you find it? It will go in class list, musculoskeletal, class list, musculoskeletal, and the last folder you'll see current. That's where you'll find it. Okay. Shruti, tomorrow, you got to think what causes posterior tipping. Thank you again, Shri. That was very helpful. No problem, Mehmet. I'll say also, in case if you decide to enroll, this is just one lecture of musculo, shoulder. You know there's hip, knee, ankle, posture, gait, PNI. it's very hard for a student when they're doing by themselves. It's very hard for them to like do all of this by themselves. We have a whole team that kind of design the notes, the concepts, and you have been doing this for 7 years. You only have few months to take your exam and pass your exam, right? You cannot spend 7 years and remake those kind of notes. Okay. All right. So see you all tomorrow. If you're not confused, not lost, again, use the same link. It will be via that link, and then we'll do a lot of discussions again. Tomorrow, you guys need to finish the conditions. Tomorrow, we'll finish all of this. Just finish the remaining part of the slides. We'll get it done. Okay. All right. Any feedback, any concerns, any problem? Shrishti, that will start in next year, February. These slides, okay, go to class list. Go to musculoskeletal. Okay, in musculoskeletal, you can read, it says lecture PowerPoints. Over there, click on notes. Okay. So yeah, make sure you guys come revise. Don't just show up. Guys will be lost. Okay. Bhumika, again, introduction will be on the website. Class list, and on the very first page, you'll see orientation. Just watch the recent orientation. Ashweta just write an email. They should be able to help you with that. If you guys joined late in the last 1 or 2 days, might take a day. Okay, I'll check that quickly. I'm not sure why it didn't get there, but I'll check that one quickly. Okay. All right, guys, you have a great night. Enjoy. See you all tomorrow. Okay, bye-bye. Thank you. And if you want to enroll, you can directly enroll. Once you enroll, you'll get access to all the lectures, PowerPoint, slides, notes, quizzes, everything. And that will be maybe 100 times better than you can just come prepared. Okay. Devika, are you already enrolled in the classes? So just follow this thing and you'll be able to find the lectures. Can we do external rotator strengthening if patient has anterior instability? We should not, but those are two different reasoning. We should avoid that. All right, so tomorrow, make sure you guys come prepared. There's a lot of things on the slides, and I request you. I know you want to read the book. I have to tell you one thing. You're not ready for the book. Right now, you got to build up your basics. Okay, build up your basics, build up your foundation. Once you're good, then yes, we'll tell you, go and open the book. Right now, if you go open the book, probably you'll give up, which is not a good idea right now. Start with lectures, build up your understanding, and then we'll tell you when to go for the books. Lecture slides, you might find more information than the book. The slides are from multiple textbooks, not in one book. Okay. All right, guys, you have a great night. See you all tomorrow. Bye-bye.